Hello. I'm Napal Phuang Wadana from Prince of Songkhla Hospital, Thailand. Today, I would like to share with you a case of robotic R-ETEP TAR repair for incisional gridiron wound hernia. I have nothing to disclose. A 67-year-old male underwent open appendectomy for rupture appendicitis 5 years ago. He had reducible mass at gridiron wound for 1 year. Physical examination showed reducible mass 5 cm over gridiron incision. The patient's abdomen before surgery. Preoperative CAT scan was performed. It revealed hernial defect at right lower abdomen, the defect size 9.4 by 13.6 centimeters. It contains small bowel loops and mesenteric fat. He was diagnosed with incisional gridiron wound hernia L2W2. So we decided to perform robotic-assisted R-ETEP TAR repair. The patient was placed hyperextended position with slight right side elevation. 3 8mm ports were placed as depicted. We began with retrorectus plane creation using 8mm optical trocar with air dissection. Continue blunt dissection with 5mm telescope. Second port insertion. Continue retrorectus plane dissection. Third port insertion. Docking robot. Retrorectus space dissection with robot. Keep dissection plane medial to neurovascular bundle. Cutting posterior lamella of internal oblique with TAR. You can see thin transversus abdominis muscle here. Dissection into the plane of lateral space. Hernial sac dissection by open reduction content to prevent inadvertent small bowel injury. You can see hernial sac here. Small bowel loop was severely adhered in the sac. Dissect the small bowel loop down meticulously. Dropping small bowel down without injury. Start dissecting beyond the hernial sac. Dissection distally to the sac. Dissection into the right brogo space. Lateral dissection to the psoas muscle. Keep fat covering iliohypogastric nerve. Complete small bowel reduction. Dissection into retsia space. Finished dissection. Flexion operative table to decrease tension before suturing. Anterior defect closure with non-absorbable barbed suture. Tightening the suture. Finish anterior defect closure. Posterior defect closure with absorbable barbed suture. Finish posterior closure. Space was measured to design mesh size. Macroporous polyester mesh, size 16 by 23 cm, was placed. Suture fixation mesh was performed. A JP drain was placed. The patient was discharged on postoperative day 2 without complication. The JP drain was removed on postoperative day 6. No recurrence at 3 months post-surgery. Post-operation. Thank you for your attention.